Hi, I'm Rozan, a resident in Emek Medical Center in Israel, and I'm going to present you today a case that looks, sounds, smells like lymphoproliferative disease and potentially as lethal in the elderly. On November 2023, an 82-year-old patient presents with decreased appetite, weight loss, and fever for the last few months. In his medical history, he has ITP and cyclic neutropenia, treated with G-CSF and low dose of prednisone as needed. On his physical examination, he has non-purpuric, desquamative, erythematous rash over his face, extremities, and splenomegaly. The lab test revealed marked leukocytosis, elevated CRP levels, mild normocytic anemia, and the LDH and liver enzymes were in the normal range. An abdominal CT was conducted that showed retroperitoneal lymphadenopathy, splenomegaly, and new hypodensic hepatic lesion. So in the first, second, and third place in our differential diagnosis, we thought of lymphoproliferative disease, but let's see. In the past few months, he was hospitalized 3 times because of the same complaints. First, on March 2023, a total body CT was conducted that shows diffuse lymphadenopathy, including axillary mediastinal, inguinal, and para-aortic lymph nodes that was suggestive of lymphoproliferative disease. So he went through an FNA biopsy from suspected lymph node that was negative for lymphoproliferative disease. He gets treated empirically with dexamethasone, gets better, and discharged on a steroid tapering down regimen. On the tapering down, he suffers once again from the same complaints and hospitalized 1 month later on April. This time, a PET CT was conducted that showed pathological FDG uptake of the lymph nodes above and below the diaphragm and splenomegaly, once again suggestive of lymphoproliferative disease. This time, FMB biopsy was conducted from a cervical lymph node that demonstrated reactive follicles and proliferation of T cells. The pathology report raises the suspicion for T-cell lymphoma, but definite criteria for the diagnosis were not met. Again, hospitalized on May, this time bone marrow biopsy showed a typical lymphoid infiltrate and trilineage of hyperplastic marrow with some myelodysplastic features, suggesting either T-cell lymphoma or reactive inflammation. So what's our differential diagnosis? Is it a lymphoproliferative disease that haven't been proven yet? Is it solid cancer with paraneoplastic presentation? Is it infectious disease, autoimmune disease, or is it something else like chronic active EBV? On the admission on November, we took infectious serology test for Q fever, Brucella, HIV, which are all negative. We took EBV serology that showed past infection, and we took EBV PCR in the blood that was highly elevated with more than 15,000 copies. Our patient looked critically ill. He was clinically deteriorating. So considering HLH, we took the lab parameters, including ferritin, triglycerides, and soluble IL-2 receptor, which all were high. So based on the clinical and lab test, he was also having features suggestive of HLH. Then we revised the biopsy that was conducted on April, and we asked for restaining for Ebersesh, Epstein-Barr LRNA, and resulted positive. So based on the absence of malignancy, infectious disease, or autoimmune disease, our patient was diagnosed with chronic active EBV. It's characterized by systemic inflammation and clonal proliferation of infected EBV, T, and NK cells. It is a life-threatening illness that could be associated with severe hypercytokemia and hemophagocytic syndrome, which might occur suddenly. And outcome is often fatal. Thus, rapid diagnosis and specific therapeutic interventions are required. It is a rare disease, especially among the elderly, and considered a childhood disease. The median age of 100 patients in a recent Japanese survey was 21 years old, and our patient was 82. So we think that our patient may be the oldest patient diagnosed with this disease. The diagnostic criteria based on the recent guidelines included persistent infectious mononucleosis-like symptoms lasting more than 3 months, detection of increased EBV genomes in peripheral blood or affected tissue, and the cutoff for EBV using PCR is 10,000. Detection of EBV-infected T or NK cells in peripheral blood or affected tissue, and chronic illness that cannot be explained by other known disease, and all are required for the diagnosis. The diagnosis was obtained after 10 months from onset of clinical manifestation, and this delay is due to the fact that this is a rare disease, especially among the elderly. One of its complications could be hematological malignancies, including leukemia and lymphoma, and the fact that malignancy was not diagnosed yet does not preclude future occurrence. The only curative treatment is hematopoietic stem cell transplantation. Other strategies, such chemotherapy or immunotherapy, can be used to reduce the systemic inflammation and control the activity of the disease. As our patient was not a candidate for hematopoietic stem cell transplantation, he was treated with dexamethasone and etoposide for the diagnosis of chronic active EBV-related HLH, and he was discharged after remarkable clinical improvement. And on the follow-up assessment in January 2024, our patient was feeling well without any symptoms. There was a resolution of the rash and lymphadenopathy on his physical examination, and EBV PCR in the blood was undetectable. Thank you.
What strikes me, I believe we had 3 cases today when we didn't know what to do. We put the patient on dexamethasone. I'm as guilty as everybody else, but it's quite striking because the treatment with dexamethasone and etoposide, this was not specific treatment for the virus itself. It was for inflammatory component.
Right. There haven't been any proven treatments for antiviral agents for chronic active EBV, so all the treatments are targeted to the systemic inflammation to control the inflammation.
Thank you. Florence, I wonder if you would feel like commenting on this quite amazing story.
Yes, thank you for a wonderful presentation. I think it's really important to remind us of these very atypical presentations. I was wondering, this is a real question, I do not know the answer. Is this something which occurs in the cases of primo infection only, or can it be due to reactivation?
There's no specific, all the data of chronic active EBV, it's not on the primary infection.
Okay, so it can be reactivation of the virus?
Yeah.
Correct, okay.
Yeah.
And because the fact that it's often in younger people, one would assume that perhaps this was a very old person who had escaped primo infection and then had his primo infection very late, but okay.
Yeah, because all the time it was considered a childhood disease, and all the patients that were documented were children. But as more awareness of the world of this disease, there are more cases of elderly are being documented with the chronic active EBV.
I also have another question because given the age, obviously you have to think, as you said quite correctly, of hematological malignancies, and one which could present like this and is associated with EBV is angioimmunoblastic T-cell lymphoma. So I was just wondering if you have any idea of was there serum hypergammaglobulinemia in this patient? Did you do rearrangement patterns for TCR on the biopsies, etc.?
Yes, actually, there have been our hematological specialties in our hospital have done all of these tests that I'm less aware of, and there wasn't.
Because it can be a very elusive diagnosis, really. Sometimes you have to try again. Okay, thank you very much.
Thank you.
Thank you for a beautiful presentation. The problem is that I always end up at a higher level of confusion. And that is you are treating, I see a lot of renal transplant patients, and we monitor EBV PCR and CMV PCR, and whenever we see it rise, we often taper the amount of immune suppression back. So give them less. And so what is happening here? We see one with a high EBV load, we start increasing the immunosuppression, and the EBV load decreases. The whole idea behind decreasing the immunosuppressant is to allow your own immune system to get the EBV out of your system. So what is happening here? What are we actually treating? Is this still a occult malignancy? Because we do treat post-transplant lymphoproliferative EBV-associated lymphoma. We treat them with immunosuppression. So I'm somewhat confused.
Well, that was my question of using 2 medications which are not antiviral, anti-inflammatory. Oh, no, there is no time at all.
Okay, thank you. I would like to ask you.
He has directly moved on. Okay, once again, there's no standard treatment for this disease especially, and it's rare disease, so little is known about the optimal treatment. But as I said, the only curative treatment was hematopoietic stem cell transplantation, and all the other strategies are just to reduce the inflammation. About the EBV load in the peripheral blood, there is correlation between how severity is the disease and how the load is high. So the goal in these cases is just to get an undetectable level of EBV.
Do you have any comment or any answer by yourself to your question? Or?
Yeah, the only thing is that actually we are missing an occult lymphoproliferative disease we are treating.
So I was asking that you have a case of a secondary HLH here. And what were the infections? You showed some of them that you excluded. Did you exclude tuberculosis?
Actually, we didn't, because it's not wide
Yes.
familiar in our country, or this patient specifically, he had no risk factors to do so.
Yeah, that is a way of answering. Yes, that is good. That is not prevalent, but in these days of international travel, it has been found that we are missing those boundaries of infections these days, and infections which were used to be common in the tropics are now being seen in the temperate areas. So I think that we should be aware that not to think that this infection is no longer common here.
Thank
So
you.
that is
Dr. Ganji, the last question of the first.
Okay. I've got the mic, yeah. Okay, maybe just to answer that question, so also for transplantation, is that I'm wondering if the dexamethasone is just a general anti-inflammatory, which often will settle the lymphocytes and inflammation down, because you kind of have to target the T cells, and I think maybe us reducing our CNI is probably helping that part out of the EBV. I'm just wondering if with respect to this particular case, if you ever consider rituximab, because sometimes in transplant patients, we actually follow, and then, because the EBV is infecting the CD19 cells, and the idea is if you wipe out the CD19 cells, you actually will gain control. And so sometimes, again, with transplant patients, we'll actually give them rituximab if the EBV viral count is getting out of control.
Actually, he has, because of the time limit I have for the presentation. I stopped in the assessment in January, but in further evaluations, he got treated with the last month he started rituximab. Yep.
Right, thanks.
Well, thank you very much. You survived through 10 cases.